Is that it? Okay, welcome back, everyone. It's lovely to be here. Well, first of all, I'm going to say this. Imagine a world where a simple infection could be fatal, where pneumonia, urinary infections could carry life-threatening risks. This isn't, of course, science fiction. It's a silent pandemic that's causing over 35,000 deaths a year in the EU. Good afternoon, everyone. My name is Mariam Zaidi. I'm an international news presenter, and welcome to Addressing the Inequalities of Antimicrobial Resistance in Europe, AMR, Addressing the Burden for Greater Collective Well-Being. Now, as everyone comes in, I'm going to ask you all, if you feel like it and feel comfortable, come a little bit closer, because we're going to be having an interactive session. So you're going to be working in pairs. So, for example, the people that are sat in rows by themselves, you might want to look to someone or look to someone who you might want to work with very shortly. Now, the question that's been asked of us here at the European Health Forum is how to fix Europe's fractured social contract for health and well-being. Now, AMR matters within all of this because it's not just a medical issue. It is when microbes or bacteria designed to be killed adapt, and they survive. And this doesn't just affect, of course, humans. It can affect, the bacteria can spread to farming, to food chains, the environment, trade. It crosses borders. It is very much a global crisis. I mean, we're, of course, discussing it within the European context, but this is a global crisis that goes to the very heart of health equity, access, and, of course, justice. There's also a massive economic cost when it comes to AMR, 11 billion euros a year in workforce under productivity. Another startling stat is that by 2050, AMR is on course to become the leading cause of death worldwide, surpassing cancer and cardiovascular disease. Now, in September, as our colleague from the European Commission knows, the European Partnership for Research and Innovation was launched, One Health AMR, with a budget of 253 million euros over 10 years. But is this response enough? Or is it perhaps just the start? Now, we have, of course, as you can see them, assembled a great group of experts, patient advocates, specialists, biopharma, and, of course, DJ Sante. And over the next hour, we're going to look at the challenges, of course, of tackling AMR in Europe. How do we understand it? The interconnected risk, the inequality gap, and, of course, those drivers, greater burden sharing, and, if I may, how the European Commission can, of course, affect change beyond current European initiatives. Now, in terms of the agenda, we're going to have a quick round of introductions, and then we're going to move on to something called the two-for-all format. Now, who in the room understands what the two-for-all format is? No one's done it here yet? Okay. Well, what it is that you're going to work in pairs. We're going to give you 4 minutes to answer a question. The pairs will then go into 2 pairs, so there'll be then groups of 4. You'll then discuss the question amongst yourselves. So all of this will take 10 minutes. And then we will ask for one of you to be a spokesperson. There'll be roaming mics. And then we're all going to discuss, what you guys feel related to the question that we have prepared for you, which, of course, you will get very, very shortly. During this, I also want to say, welcome to our online audience. During the time that we do the two-for-all, we're going to ask you all to participate in a word cloud. So don't worry, online audience, we are not forgetting you either. Then we'll move to a 30-minute panel debate. Then we will have some time for audience questions. And if during the two-for-all we haven't gotten around all the groups, we'll then come back to what you guys have found together during the audience Q&A. And then, if there are any final thoughts from our panelists, we will give them the floor as well. Okay, so without further ado, let's get to our amazing panelists then. First of all, Vanessa Carter, founder and executive director of the AMR Narrative and a former AMR patient. We have Professor Wojciech Waleszko, pediatrician from the Pediatric Pulmonary and Immunology Department at the Medical University of Warsaw in Poland. Anna Thomas, she's a chief scientific officer at OM Pharma, a Swiss biopharmaceutical based in Geneva. And last but not least, we have Arjen van der Stappen, the head of unit antimicrobial resistance at DJ Sante. Okay, so first of all, we'll give all the panelists a chance to speak. And Vanessa, we'll start with you.
Yeah, thank you so much, Miriam. Yeah, so I guess, you know, we're all here for patients. So I know I don't have a lot of time, but I'm just going to start with a very brief part of my story. This is a snapshot of me over my patient experience. We call AMR a silent pandemic, but you know what? AMR was never silent in my life. In 2004, after a devastating car accident, I lay on the side of the road while paramedics fought to save me. My body broken, my abdomen torn with internal bleeding, my face and pelvis fractured, and my neck and back severely injured. But that was not the worst of it. 6 years later, after surgeons had inserted yet another prosthetic to rebuild my face, I developed a vicious infection, one that would not go away no matter how many antibiotics I was prescribed. I was bounced from specialist to specialist, enduring 11 relentless months of surgeries until at last the infected prosthetic was removed and sent for testing. This was the first time that I heard the word test. I still remember calling the pathology office, desperate to understand what was making this infection so special, because I didn't know why the antibiotics weren't working. It would take another year before they could attempt surgery to repair the gaping hole in my face, eaten away by resistant bacteria. But the operation only led to yet another infection, this time spreading through both my facial skin and bone. We rotated last resort antibiotics, and slowly the infection healed. But I soon found myself on my second deathbed, this time from an adhesive bowel obstruction that required 10 centimeters of my intestines to be removed. Maybe it was a consequence of my original stomach injuries. Maybe it was the excessive use of unnecessary antibiotics, toxic antibiotics. Nobody could tell me. So it was then that I made a promise to myself, if I survived, I would raise my voice as a patient and advocate for others, which is what I do today. So many system failures had brought me here, and in 1 minute I cannot address them all, but I encourage you to think about this dynamics of AMR, because it's very cross-cutting. So thank you.
Thank you so much. I think this is a round of applause. And we're obviously going to hear a lot more from you a bit later, but Professor Wojcik, over to you.
Yeah, I'm basically frontliner. I'm practicing pediatrician, and I face the need to limit antibiotic therapy in my patients. What we see is that the pediatric population in whom we do prescribe a lot of antibiotics is a sentinel population into which we really we tend to over-prescribe antibiotics. And what we see here in Europe is, if you would have a map of antimicrobial resistance here behind us, we would see a borderline between the West and the East. And I'm Eastern European, as you know, and we face a problem of increasing antibiotic resistance among Eastern European countries. What is the reason for? We can discuss about it, and I'm here to present my perspective how to fight against it.
Indeed. Next.
So as you cited, AMR is cited as a leading cause of death 2050, and actually very emblematic and ambitious timelines have been set on the EU scene and globally, so to reduce by 20% the use of antibiotics by 2030, reducing deaths by 10%, and actually 2030 is really at the door, is tomorrow. So even though already the AMR fight is really on the top of the EU political agenda, I believe it deserves even more action, even more attention. For example, in the role that prevention could play, because prevention is not a side strategy. As Feleško, you indicated, the issue of AMR, about the antibiotic use. So prevention is not a side strategy, and using it more broadly, beyond indeed sanitary measure, beyond vaccination, but taking it with other measures could really help being used as one of the effective, it has been shown to be cost-effective measure, the prevention effective measure to tackle and help this AMR fight. So I'm convinced actually that today with this kind of dialogue with all the stakeholders that are contributing to it and want to contribute to it, we can elaborate actions, think of strategies, and most importantly, thinking of how to implement them, meaningful action to help solve this critical public health threat.
Thank you. Thank you so much. Last speaker, Ariane.
Thank you very much, and good afternoon to everyone. So thank you for telling before me that indeed AMR remains a top priority in the political agenda of the European Commission. AMR situation is critical, and we know that if we don't act swiftly and with decisive instruments, it will be only worse. So very clearly also is that all member states are concerned. It's true in different ways, and we will discuss that further today, I'm sure, but nevertheless they are all concerned, and no single country, no unique region in the world will be able to address alone this problem. So collaboration, cooperation is not an option, is really an obligation. So of course the Commission will continue to provide tools like legislation, implementing what is already existing for AMR. Hopefully the pharma package legislation will be adopted soon with, I hope, clear incentive for innovation and also clear provisions regarding prudent use. We will continue to develop guidelines for member states. We can also further develop, I would say, instruments that are more dedicated to the citizens, like games for young people, like Beat the Bugs. If you want to know more, I can explain later, but it's really something that targets young people. We will also next year do a Eurobarometer again, because in 2022, one of the outcome was that half of the audience didn't know that antibiotics are not efficient against virus. Hopefully in 2026 we have another kind of answer, and then we can tailor our actions. I would just say the following to end is that it needs absolutely to remain a high, I would say, political ambition also at national level. We need to reinforce actions where it matters the most, and I will just say that in hospitals where resistance to last-line antibiotics is of utmost concerns. Thank you.
Okay, thank you so much. Thank you. I think both of you also brought up the idea of antibiotics as well, which is something we will discuss. Okay, so now I want everyone just to quickly break away into your groups. So you're going to have to put away your phones. I can see some people looking at their phones. We're going to do the 2-for-all format. So yeah, so everyone get into your pairs. You guys can get into pairs as well if you want to play. Christian, go for it. So what I'm going to do is I'm going to pose a question. It should be up there for you. Yeah, so that is the question. Which measures do you think should be further prioritized to tackle AMR? Everyone quickly hurry up. You've got to get into your pairs, please. Everyone, okay, Neil, I can see you can take a friend there. There we go. Come on, everyone, please, quickly get into your pairs. So you're going to answer this question. You know, where do you feel as if within the countries or region, where is really the burden felt greater? And where also is there perhaps gender disparity or societal inequality that also adds to the burden of AMR? Perhaps something one of the panelists has said has resonated. Okay, so we have, as I said, you've got 4 minutes. I'm going to put a timer on my phone. You've got 4 minutes to discuss amongst yourselves. When the 4 minutes is up, I'll then ask you guys to then go into 2 pairs. So yeah, so go for it, guys. Discuss amongst yourself for a couple of minutes, 4 minutes to be exact, and then we'll come back to you. You can do it as well.
So what do you think? Which measure do you think should be part of this? You have probably studied that.
Mais pour moi, le ça dépend dans certains pays. Je vois pas le awareness raising en Suède, c'est pas nécessaire.
En fait, c'est que j'imagine que c'est pas du tout one size fits all, parce que la situation des pays n'est pas du tout la même.
Is it diagnostics in primary care settings or more advanced?
Nous, je pense que la meilleure chose qu'on puisse faire, c'est...
So that the primary care physicians do not prescribe so much, right?
Non, c'est quand on veut vraiment avoir des bons projets.
Et comment se passe la chaîne de décision, justement, commission versus justement les États membres? C'est-à-dire comment vous pouvez enclencher la machine?
On a le multi-framework,
oui.
from Europe,
Est-ce que c'est monitoré en fait ce que font les pays avec ça, les autres? Oui, c'est
Mais maintenant, ça va d'abord passer au conseil. On va voir si, par exemple, il y a des possibilités
Et du coup, les priorités de santé, par exemple, là sur l'AMR, ça s'est décidé des autorités européennes, mais après le member state peut dire non, moi je pense que pour mon territoire national, je suis plutôt sur ça.
on a des budgets européens.
Ouais.
Donc, c'est alloué sur la recherche. Parce que là, c'est pas de l'argent.
Mais alors, oui, ça peut être projet de recherche ou awareness, vous aidez aussi sur les programmes d'awareness, parce que
des campagnes
sur l'antibiotique, etc.
Oui,
mais oui, c'est
Fortnite. On touche que les garçons apparemment, mais ça a énormément de succès. C'est vraiment très bien. C'est super-héros.
D'accord.
Et
puis du coup, il ne peut pas tuer les il ne peut pas libérer. C'est ça, il faut trouver des tools en fait,
Et alors, et des teaching matériels, des écoles, ça, on a fait dans 6 États membres, et ça, je crois que 4 vision, ou en tout cas, les jeunes, je crois qu'ils suivent les influences, on a utilisé des influences.
Just quickly, just to say to the online audience, don't worry everyone, carry on, carry on. The online audience, don't forget that you need to participate in a word cloud. So we are not forgetting you, so please carry on.
Vraiment faire ce qu'il faut.
Awareness. Ça, on demande de faire des grandes je crois plus de déjà tous les États membres. Parce que seuls savent ce qui marche.
Okay, everyone has 1.5 minutes to go.
Et les campagnes, c'est difficile. Ça n'a pas bien marché. C'est pas des campagnes qui ont été filmées à 50 millions d'euros.
Ah oui. Ah ouais.
Une vraie campagne européenne qui va avoir un vrai impact.
Somebody's coughing and fear. No time.
Est-ce qu'il y a des manières de faire sous forme un peu pilote, c'est-à-dire dans un pays, même une région en Inde, et puis voir une fois si ça marche, l'étendre aux autres, ça vient un peu.
On peut faire ça, oui. On l'a pas encore fait.
Parce que c'est vrai que
Awareness campaign, c'est très cool.
c'est ça. Non, mais vraiment, c'est vraiment brûler les ailes. Nous, on le voit enfin, même en format sur des awareness campaign, ou digital awareness campaign, ou choses comme ça. Ça peut complètement sortir.
Parce qu'il n'y a pas un soutien, en fait.
Both healthcare professionals and public.
Ça marche
Alors
pas.
là, ça va être une antibiotique, ça fait des années que c'était un problème de compréhension sur l'utilisation des antibiotiques. Ça évolue de très très vite.
Tu les avoir sans presque.
Non, c'est fini. Effectivement, voilà, c'est les 3 boîtes, la prochaine fois je les prendrai dès qu'il y en a malade, l'automédication, pourquoi faire?
Okay, everyone. Now please find another pair, and you've got 5 minutes starting now. So just to remind you all, the question is, what measures do you think need to be further prioritized to tackle AMR? Are you looking at infection prevention, reducing transmission perhaps, preparedness, antimicrobial stewardship, development of new antibiotics? What do you guys think should be taken into consideration?
Yeah, we found a solution already. Not all yet. It's a long way ahead of us. Yeah. we do it. Now we're discussing 4, yeah?
Yeah.
Good. So.
Well, you guys better have the... So the panelists are also working on the 2 for all. So guys, you better have good answers. Let's see if theirs are the best.
Public education, healthcare professional education is a...
I'm a big fan of education.
Yeah.
What can only be done at national level in the proper way. So we can change best practices with the member states to see what works best. It needs to be done, I would say, really kind of endorsed and supported by the member states. We cannot claim as a
I allow myself to disagree with you, since we have a national action plans in particular countries. However, if we harmonize them, we see the difference. Europe is such a fantastic place where you can see see what we
And
can
what we do, we exchange practice and how we can do better.
Jamai.
Jamai is
I think we harmonize the practice in how to monitor the AMR.
Oh.
With the Dutch. Physician who prescribes more, they're going to send it to a special, educational course. You know it? It's something which we really need in the rest of Europe. Because some countries, they prescribe that crazy.
But they have this network called One Health AMR network, where every time we meet twice a year, a member state can explain what they do, for example, to show best practice, also stewardship measures, and exactly that one was one of then you can see if it's transferable to Cyprus. Send someone to
I had a professor from Rotterdam in my university giving a lecture about treatment of pneumonia. She told us a story how they separate patients with coronavirus, with Staph aureus and RSA from the rest of the population in the beginning in the hospital. You are aware of that?
No, not one.
That's the Dutch procedure.
They separate people that are sick in
Livestock keepers. And this is also, my students were like, it's a new Holocaust, how can you separate people, But this is probably a way you can skirt, from really harmful situation like your situation.
I really believe, and we have seen that with COVID, it depends really on the culture of the country, because certain measures work well in one and not in others. And we have seen that in some of the member states, they like kind of very strict measures. In the north, they are a bit more responsible from the state, and they themselves a good attitude. So that's why I'm saying it's
very difficult.
It's really difficult what is behavioral related to harmonize. That's at least what I have learned so far.
So the education, you mean, is only one thing?
No, education I think is universal. But what you meant that separate the sick people from it's not an easy thing.
It has to be adopted.
Yeah, especially because it's not.
How you doing, panelists? You doing good?
Yeah, exactly.
You've got 1 minute. Everyone's got 1 minute.
She's spoiling our game.
Don't get scared. Don't get scared. Okay, does everyone think they're sort of ready? Put your hands up if you think you're sort of ready, because the clock is ticking down. So does everyone feel like they're sort of ready? Everyone's got an answer? Everyone's still talking? Put your hands up. Everyone ready to go? Okay, you had 15 seconds extra, but I'm going to take it away. Okay, so where are the roaming mics then on the floor? Which group? Who wants to go first? Which group? Who's ready? Okay, I'm sorry, Christian, I'm going to pick on you first then, your group.
Thank you, Mariam.
My pleasure.
So we discussed different options. One, of course, was prevention, and indeed they appear on the screen. This was probably from the Slido online, but less antibiotics. So implement more the concept of antimicrobial stewardship, especially also in the community. Raising awareness, so health literacy around AMR and use of antibiotics at patient level, at population level, and prevention in the broad sense of the term, yes.
Perfect.
That was main outcome of our 2 for all.
Thank you so much. And Christian is also from OM Pharma. Okay, so next we'll go to the other side of the room. Who wants to go? Ladies, I can see. Oh, Niels, do you want to go? Your group? Go for it, go for it. Choose a spokesperson. Please take a mic.
So we landed on one policy, it's more data. We need to know what the root causes are and where it's happening. Is it in hospital setting, community setting? So we're from different member states. The situation is different everywhere, and we think if there's good monitoring in place, the measures, like the right measures, will follow from that.
Perfect, thank you. Go to the other side of the room. Ladies there, yeah, please go for it. So we'll keep switching side to side, so get ready.
Thank you, John. We discussed 3 issues. For one, health literacy is key, as already was mentioned on the panel. So when to use it, how to use it, how to dispense it. At the same time, also the healthcare professionals have to be trained how to prescribe them and when. Then no overuse in animal health. And the final issue is the pipelines are empty, so there should be incentives to develop new antibiotics.
Well, I know one panelist specifically will like that one. To the other side of the room again. Yes, please go for it, ladies.
Hello, thank you. So we were discussing 3 points, or maybe 4. First is test, and have the results very early. So doctors or practitioners should test before giving antibiotics, whether it's a virus or a bacterium. And then we also discussed a lot the hygiene standards in the clinics, because that's where the bugs spread, and we were all concerned about this. So we should really make sure that in the clinics there are excellent hygiene standards, and I think there are a lot of good practice examples out there. And then also take measures for less antibiotics, as we had already heard. Thank you.
Thank you. I think what you said about hygiene is quite important, because obviously after the pandemic, what did we all do? We all started washing our hands, and then where has the hygiene gone now? Okay, next. Over the group that side. Yeah, go for it. Who wants the microphone?
Yeah, I don't see anybody.
Do you guys want to grab it? The guys there, just behind you there. Yep, go for it. Whichever one of you is brave enough, go on, go for it.
Hello. We were talking about health literacy, but among the population, because they are always wanting something in a hurry, like they have an infection, they want a medicine. They don't want to wait for the microbiology test results. So sometimes we need to do that part, not just among the doctors and the healthcare workers teams, but among the population too. Thank you so much.
Thank you. You can pass the mic to someone from the other side as well. Go on, go for it. Who wants it? Who wants it? Who wants the microphone? Go on. Don't be shy. Don't be shy.
I think we don't have anything new to add. We were talking about awareness raising and tailored target group-oriented awareness raising. Thinking about different communities, population groups, but also health professionals. That was our main point, I think.
Thank you so much. What about the guys at the back? On this side. Were you guys taking part in the 2 for All? No, but I can see you're smiling. So the gentleman there who's directly at the back, is there anything you'd like to add? What is the one sort of key word that comes to mind for you when you think about AMR? One of you at the back, go on. Don't be shy. You're all health professionals, all working within the sector.
I'm a bit shy, sorry.
Don't worry, go for it.
We were also talking about reducing the use of antibiotics and therefore looking at doctors, how they could use more point-of-care testing to be sure that antibiotics is a good idea. And also looking at the patients, increasing their knowledge when to use antibiotics, maybe not keep antibiotics in the storage and use them whenever they feel a bit sick. But only use them when they are really prescribed and useful.
Thank you so much. And I presume are you talking there about everyday people?
Yes.
Yes. I think we all have, well, not we all, because we're in front of all of these lovely panelists, but sometimes we do have bad habits. Perhaps people right at the back will go to you and then...
Yes, okay, thank you. For human medicine, we were just discussing what's the current situation in our countries. But we have to keep in mind that there should be a possibility to increase the curriculum for medical students and pharmacists. and therefore also to promote actually when prescribing an antibiotic to have the possibility of a mandatory antibiogram. And also as a third measure, we were discussing that there should be a possibility for incentives to make available older generation antibiotics, because currently, for example, in Bulgaria, some of the antibiotics that are older generation but still effective are not available.
So you guys are looking for innovation then. Are there any more groups who haven't gone? Or is everyone okay? Everyone feels happy? Okay, perfect. Okay, well, let's turn to the panelists then, because they also got involved. Let's see if their answers are better than everyone else's. Who wants to be your spokesperson? Professor Wojciech, I'm going to pick on you.
Yeah, that was an interesting perspective you shared with me. I mean, the awareness is a really important thing, and I would, if we have discussed here in our four here on the stage, and we are the same mind that awareness is number one. Let me face a situation in which I am sitting in my office and I say to my patient, I would not like to prescribe an antibiotic to your kid since this is a viral infection. I would swear like more than half of the patients I encounter in my office would require an antibiotic. So the public awareness is really essential, since there are many people still believing we can fight against viral infections using antibiotics.
But can I ask you something? Where has that come from? Because I know myself, obviously now that I'm very learned on health policy, etc., and how health works, but even I've said it in the past when I was younger. I've said to my GP, when I had a virus, I've said, give me an antibiotic. So where has all of this come from?
Yeah, I don't know. This is probably a tradition or something. And also physicians themselves are not separated from this knowledge. They also share this point of view. It's highly country dependent. I do know that in some countries of Western Europe, like Scandinavian countries or Dutch, the physicians try to not to prescribe too much. And I strongly believe one of the solutions we may overcome this bad situation is the availability of quick tests. So let me share my perspective shortly. In 2023, after the COVID pandemic, we get the quick test, and there was a game changer. So I'm really a big fan of COVID-19 pandemic, since the sorry for that, but technology has developed and landed in our hands in order to test our patients in office. Some of my patients just calling me, they bought already in the pharmacy and they're saying, I got flu, or I got COVID, or I got RSV. You know what happened in my country, for instance, last year? The sale of anti-flu medication, oseltamivir, was so massive that it disappeared from pharmacies. So these are the patients who probably a year before would get an antibiotic for their cough and fever with lack of good diagnostic tools. So diagnosis and awareness is essential.
Well, let me ask this to you then, Ariane, then. I mean, what do you think we, or I could say the European Union as a whole, has learnt from the pandemic? Because we've all sort of understood better hygiene, better practices. You were saying, Professor Wojciech was talking about, people, the urgency of testing. But what do you think has come out of it realistically? And as you sort of answer that, I also want to ask you, where within all of this do you think the understanding of AMR has come to the wider general public as well? Because the pandemic made us more aware of our health, but has it made people aware of AMR?
Thank you very much. I will start and pick up on your last point, which was how to make AMR understood by the general public. And I will pick up on what Vanessa said, because testimonial, I think, is the more powerful mean to make AMR not something abstract, but concrete. So all the measures that have been gathered on the screen and mentioned by the audience are all good instruments to address antimicrobial resistance. There is no one solution that fits for all. Member states are in different situations, and probably an awareness campaign, let me call Sweden, will not be that necessary, while it's of paramount importance in other countries. So I think we need to see which are the instruments that work the best in the member states. You made a reference to COVID. What we can see is that there are very different social behaviors in the member states. Experience with disease is also different. Member states were affected differently. With antimicrobial resistance, it's the same. People are facing different situations in member states. Climate change does not affect all member states in the same way. So there is really a need to see what works best for your country among all the panoply. But for sure, we heard about the need of having new antimicrobials, quick tests, giving the right ones. It's all valid, but you need to know where you stand. For example, small member states, they have less access to antimicrobials. They may be on the top of, we call front runners, because they are very good, but small countries like Denmark, I think, sometimes they have difficulties to access to antimicrobials. So it's really assessing the situation of the country and provide all the tools that are necessary and try to see where you can make the difference.
Well, let's come back to Vanessa then. I mean, obviously, you know, your story is, you know, what happened to you was horrific. Do you feel as if the health policy today has changed enough to protect people against getting something similar or getting infected to the extent that you were? Because you seem to have one after, you know, the next, something kept happening to you. Your body started breaking down. And do you feel as if you, at the time, you got the right kind of healthcare eventually? And what has changed now? Has it gotten better at all, do you think?
Yeah, that's a good question. So, you know, I started advocating 13 years ago. I've been going ever since then, and so I've seen the progress from when the Global Action Plan was written in 2015 to the first United Nations high-level meeting held in 2016, and more recently the United Nations high-level meeting for AMR in 2024. There has been some progress, but there hasn't been enough progress, and there's been a lot of commitments being stated, but that doesn't mean that, you know, just because these national action plans are being written, for example, that they are actually being implemented. And in fact, the last that I checked, there were 170 national action plans, only 11% of them were actually being funded. So is there progress? You know, I, as a patient advocate, I go out and I speak to the communities and I say, you know, I wear the scars of AMR on my face. So I often get the question, what happened to your face? And I get into that conversation of, well, you know, I had a car accident, I had a facial reconstruction, I had a resistant infection, and AMR. And they kind of go, well, what is that? So we have a huge amount of awareness raising to do. And yeah, and I think that the most important part about that is because we can keep on, you know, finding new antibiotics and so on, but unless we actually create behavior change and we work collaboratively, not just with doctors and so on, but also patients making more informed decisions. And that could even start with not even just your patient to provider conversations, but also at a very early age, teaching us in schools about the microbial world. You know, we all had a very big wake-up call to say, oh, you know, this virus, COVID-19, hang on, you know, we started understanding that there was I don't think people still grasp that yet, but the difference between viruses and bacteria, and actually that we only take antibiotics for bacterial infections. We need to do a lot more, and I think that, you know, going back to that again, I think we have a lack of funding. I think also something else we need to be doing is how are we going to implement those national action plans? I think that a lot more community outreach, and actually, and I'm going to say this from a patient advocacy perspective, is to actually work with community organizations on the ground.
So for you, do you think that the biggest hurdle right now is actually the lack of, would you say understanding, or is it the communication? Because healthcare professionals, they understand risk, but are they perhaps communicating it? And perhaps Professor Wojcik, we can come to you after that, but do you feel as if you understood the risk, you know, when you faced your health crisis?
I didn't know what was happening to me at all. And so what I think is that medical education is lacking the patient perspective within that medical education ecosystem. So there's been times, for example, where I've gone and presented my patient story to pharmacy students, to different universities and so on, and it just helps to, you know, for them to kind of understand and see how they can communicate better. So that's a huge thing. And diagnostics, believe it or not, was one of the biggest turning points for me, because when I had that diagnostic test in front of me and it said MRSA and it had the different types of antibiotics that I was either resistant or susceptible to, I suddenly went, wow, what is this? And I could start to educate myself. And I could start to work with the doctor to ask him questions. So I think that's a very, very huge part of it. I'm a big advocate for diagnostics. But also multidisciplinary teams. Often doctors work in silos. I don't know so much in Europe, but often antibiotics are prescribed. I'll use one example, for example, dentistry. Dentistry, I come from South Africa originally and I live in the UK. Dentists work very separate to GPs and they prescribe in their own little silos and it never really ends up being, tracked as extensively as it should be. So lots of things to change. As I said, it's a very multifaceted issue to solve. But if we could get to a point where when we learned about smoking and how smoking caused cancer, that behavior change that came, people made more informed decisions. That is the point that we need to get to now. We don't want the doctor to say, you actually don't need this antibiotic. We want the patient to say, do I need this antibiotic? And I think then, yeah.
Anna, perhaps we can come to you then. What is the role of biopharma then when it comes to communication and education? Because you guys are the ones, creating these drugs for us that we all need.
For sure, I mean, it's a key part of the awareness that should take place, is starting with the data. And actually that's the part where we as pharma can play a big role and help on that perspective, providing the data, providing innovation, providing actually the messages, or trying to find a way to speed up the speed at which actually we would have the public understanding, but the professional understanding as well. So I think it means all, and it's always what we say, we're all working in collaboration toward the same objective. So combating AMR, as we saw from the response from the panel, from the audience, will take all this multidisciplinary, multi-facet perspective. And the pharma here is really eager to help by providing data, innovation, when indeed as well, when we are working with our own medicines, meeting the doctors. In our case, when pharma, we're focusing actually on prevention of recurrent infections. So we'll come back to the prevention side, I assume, afterwards. But that's something not to be forgotten when we talk about innovation. It's not only antibiotics that will be, of course, part of the solution. That's critical to find new antibiotics that, because the current ones are failing. But it's actually about trying innovative approaches, like using prevention to its full potential, because, of course, the less infection there is, the less risk of misuse or overuse of antibiotics. So I believe that here, the awareness on the antibiotic use would be multiplied in terms of efficiency, with as well using all the tools at our hand, including prevention.
Well, Professor Wojcik, perhaps you want to comment. I mean, where does prevention start for you as an HCP?
Yeah. I mean, this is association that if you prescribe an antibiotic, not essentially means that your kid will develop antibiotic-resistant bug in his organism, his or her organism, which will destroy his organs or on a bad way. I mean, these bugs really exist nowadays all around us. I had a chance to treat a small girl of 2 months with a urinary tract infection. She got already in her bladder a highly-resistant bug, which obviously was not her bacterium. She got it from the family members. And I personally know people who got a very fancy neurosurgery procedures or cardiac surgery procedures. They got infected with very bad bugs like the EMSR, the Staphylococcus, highly resistant Staphylococcus aureus, fighting with different complications for years and finally dying because of this complication. So we really need to make this association between a single prescription and that what may happen to your uncle, to your grandfather or family member after a few days, after a few weeks or so. And I want to address also what Anna said. I mean, because the popular association is that pharma will develop a new antibiotics. It's going to be a solution. It's wrong. It's absolutely wrong, since the new antibiotic will be a target for antibiotic resistance by the bugs very quickly. To make you aware, the new daily strain, which is high resistant to everything we don't have any antibiotic which can kill this bug. So we have to take advantage from the power of the immune system. In many situations, I'm a very big fan as a clinical immunologist of that. We have antibodies that may limit the use of antibiotics, but this is not the time to address it very much into the details. Thank you very much.
Anything you'd like to say on the back of that?
No, I was just nodding, agreeing with Professor Feleshko.
Yeah, no. Immune system is a clue.
Well, listen, look, we're halfway through, so let's go to Jan. Jan, do you have anything that the online audience have been saying or remarking? Or do they have any questions?
A lot of contribution around data, new technology in the pipelines on AMR, the patient-doctor relationship, as you referred to, also the levels of antibiotic consumption, and also a lot of questions resonating with the topic of the session around inequalities. A few examples of these questions are, can the speakers describe the extent of AMR inequalities, in which countries are the most at risk and why? This is a first question that we had from online. Another one is that inequalities in access to antibiotics are also considered as a driver of resistance. And so there is one of the participants who is asking, how do you think we should address these inequalities in access to antibiotics? And then a last question, still on the inequalities, but more on the differences between the disease areas. One participant said that AMR has an uneven impact on the different disease areas. And so he or she is wondering how to strike a balance between common messaging on one hand and a disease-specific approach in terms of communication, I assume.
Okay, so I think, Professor Wojcik, you can take that last one. Ariane, you can talk about the member states, and then inequalities. Ladies, it's up to you between Anna and Vanessa who wants to take that one. Go ahead. Should we take the European approach first? So the question on the member states.
So member state inequalities is a fact. I mentioned already the factors for that, so I will not be too long, but social behaviors, experience with resistance to antimicrobials make a big difference. I recall always a colleague of mine saying that when she went to Erasmus in Sweden, she came from France, sorry, but her mom put in her bag a full bag, a big one, of antibiotics, saying that if you go to Sweden, you will suffer quite a lot before getting one antimicrobial. And especially when you are 18 years old and you are generally in good shape. And so there you could see in, I would say, countries not so far away from each other, the big gap. So, as I said, the awareness is quite different, the experience also that have been dealt. But I would like also to nuance a little bit this issue of the good countries that know everything, like, and we know them, I can name them, I prefer to name the frontrunners than the other ones, but the Netherlands, Sweden, Denmark, they have good result, I would say, with the measures they have taken. It's true that all member states have national action plans. They have adopted them. All of them are implementing them, but it's a fact that certain are more advanced in how to implementing them with really good actions that have a good result. So that's why we have this network with member states where they can exchange on best practices among each other. I would also like to pick up on one thing that's important and where certain member states have also a different approach is the fact that, someone said it, we need to test, but also what we give to animals. So animal health is an important component. And so I would bring here the One Health approach. It's kind of a buzzword recently, but it's at whole is meaning, as long as we work I would say in silos, sector by sector, we will not get the result we would like to reach. So human health and animal health, I think with clear targets are already quite, I would say, on their track. But to bring also the environmental dimension, this is still quite a challenge for a number of member states. So I would say One Health approach is more or less developed in certain member states. And finally, I would like also to nuance the fact that there are good and bad ones, because certain member states, they may not be part of the frontrunners, but they have also sometimes good results. I read lately from Malta that they have good progress regarding certain resistant infections because they have taken behavioral science interventions. So there you can see, again, it depends where you are and what is your key issue.
But let me talk specifically. I mean, you mentioned the One Health AMR. So there is this, you've got this quite a big budget. It's what, 253 million euros. Where does that money go? And then I think for a lot of people, especially in the audience and even the panelists, how do you ensure, your unit at DJ Sante actually ensures that this isn't just another fund, another paper, another set of, proposals, but there's no real concrete action. So how do you really affect change from where you are?
Yeah, luckily it's not only me dealing with that bunch of money, it's also DG Research and Innovation. But indeed, it's a good question. We have now 250 million for research and innovation on AMR as well. So the idea is to have synergies between national and European research, first of all, so to avoid any overlap, duplication. But then, of course, research, you want that it's not only the publication of certain papers, but that it makes difference with what we have on the market. And there I can give maybe a good example, a recent one with Blaveo, which is a new antimicrobial, where the research was EU funded. Two of the clinical trials were also funded by a program, and accelerated assessment procedure was used by EMA, or European Medicine Agency, to make it quickly available, and it's now on the market. So there you can see the link between research and quite not years and years before the product is on the market. So we really try to transform this research into concrete, I would say, output, and I hope we will have more in the next years.
Indeed. Well, Jan also talked about a question from the audience, the online audience, about inequalities. And I think there we can also sort of tag on this idea of the interconnected risk. So which panelist wants to take that question? So the inequalities when it comes to AMR. Perhaps, Professor, you could talk about that, the inequalities. What are they? Is it gender-based? Is it based on access to, to doctors and to medical professionals? Is it, do we have these inequalities perhaps because of, lack of education? Where does it come from? What are the biggest problems?
My personal perspective is the inequalities come from different cultural differences between member countries. We have different cultures, we have different views, we have different education levels. We are so happy to be in Europe to compare each other, how do the others do, and take advantage from the others. So I do feel what we need is we need to learn from the others, but we have also to learn how to apply these tools to limit the antibiotic use in order to harmonize measures among member countries in antibiotic, in AMR supervision, in training doctors, and also raising public awareness. What we also need is to maybe increase awareness about the immune acting factors like antibodies. It has been a new antibody introduced recently in Europe, nirsevimab, against RSV, respiratory syncytial virus, which may help to limit the use of antibiotics. As you probably are aware or not aware, many infants are hospitalized with this virus, and many of them, like 30% among European countries, are given antibiotics. So if we use modern tools to prevent some viral infections, probably this is going to be one of the contributing factors to limit the use of antibiotics, and definitely some of the European countries are underfinanced in this term.
Is there also a problem that, we've seen since the pandemic, healthcare systems were basically, on their knees. Doctors, GPs especially, they were inundated with people coming to them with all kinds of problems, backlog of people with, serious illnesses and diseases. So is there has it become a problem that GPs or user healthcare professionals feel that they need to act fast, and therefore medicine is prescribed, and also you've got this added element nowadays where people, a lot of patients aren't seeing their doctors in person. It's becoming telemedicine, phone calls. So where is there some, because of the way in which society is moving forward with technology, is that perhaps becoming a slight issue now? People want it fast.
Yeah, that's right, absolutely. I do agree with that. There are some countries in which GPs see their patients on a very comfortable manner, and there are countries in which you see like 80 patients per day. We still do better than China. When I had a chance to talk to doctors, when I have like 2 minutes for patient, what is the time for? Only to prescribe an antibiotic, and no wonder that China is leading in AMR all over the world. So we need better diagnostic tools and a little bit less time pressure to physicians. That's the solution.
Okay. And was there anything else you'd like to add on to the question about inequalities? And then perhaps the role of pharma when it comes to addressing that, because you've got this, whether it's gender, socioeconomic.
Sure. Actually, we are trying to address the needs of all the patients worldwide, so irrespective indeed the countries they're coming from or the economic situation. For example, we are present in more than 100 countries worldwide and investing in large clinical studies globally, so including indeed in Europe, Eastern European countries that you mentioned, of course, where the AMR threat is even bigger. But in countries that are not part of the EU. So indeed, we are trying to cover the needs and address the needs worldwide. But it means, and we touched upon this idea of localization, because it's never one size fits all. And medicine is obviously a good example for that. So the way indeed that there is the patient talking to the doctor, then the doctor getting the medicines or being aware of the medicines, that depends so much on the countries. The time that indeed the pharma would have to explain about the drug to a certified doctor varies so much from country to country. The time with the patient, between the doctor and the patient, would vary very much. So it's about localizing what makes more sense locally in the health system, in the public health system, and how, indeed, as a pharma, we can optimize the fact that the patient will have access to the drug he needs, or he or she, obviously.
Well, as pharma, as a representative of biopharma on the panel, do you think the regulatory environment in the European Union is what it should be, and do you have any perhaps asks when it comes to that?
I think a lot of effort have been already put in place and started, but obviously the whole goal is to have the patient receiving the drug they need as fast as possible, so having not too much lag between the development phases. So it's about clinical trial application. It's about then getting the authorization from the health authorities, where indeed this, for example, the accelerated pathway that Ariane mentioned, of course, it's a great example, because when there is a special need, the timing of review of marketing authorization application is quite long. And compared to other countries in the world, not to name a country that's not really in fashion at the moment, but it's sometimes not really competitive. But I understand that, lots of efforts are being put in place. There's the pharma regulation package upcoming, being discussed at the moment. So I'm really hoping indeed that it will be in the interest of everyone that the science can be translated to patient use as quickly as possible.
Okay. Is there anything you'd like to add to that as the DJ Sante representative on the stage?
I fully share the hope that indeed in the pharma legislation we will have the right incentives, and not only to produce new antimicrobials, because I think it was said it's not the absolute solution, because when you have new antimicrobials, if the pattern to use them is the same, the resistance will come too quick to be able to, again, being innovative quickly enough. So it's kind of a vicious circle. So prudent use, keeping people in good health, making people aware about what it is, training, education will remain key points in that. And with the Critical Medicinal Act, which will come very soon as well, the access to antibiotics everywhere should also be facilitated, hopefully, because that's also a problem for certain member states.
Okay, well, we've got about 1 minute left for the panel debate, so before we go to the audience, let me just ask Vanessa one last question. No, I'll come to you first of all, don't worry, stay there. So, you know, obviously you are the person on the panel, you're the patient perspective, but you're also someone that, of course, suffered something really horrific. You know, you've heard the panelists speak, you know, whatever we're discussing, whatever we can tweak the system, but what does success look like to you from a patient perspective? What do we need to get right, whether it's now, 5 years or 10 years? What would you like to see changes? Because we understand it, you know, we're living in a world right now where budgets aren't infinite. You know, there's lots of different things going on in the world. I mean, Ariane and I were talking about it before this debate. You know, there are wars going on. There's inequality. There's so much. You know, people are really living on the breadline. There's so much to be done. Whether you're looking at health, you know, defense, so many areas in the world, people are quite miserable. But one thing we all need is good health, or we'd like to have is good health. So what would success look like for you if we could do one or two things?
Okay, I guess, you know, because I've lived in 2 different countries. I've lived in South Africa, which is, you know, sub-Saharan Africa has got the highest impact really of AMR. It does have. And the problems are extremely different. I mean, you know, our National Action Plan and our Ministerial Committee, for example, National Action Plan has expired because we were relying on international aid. And so focusing just on that, I think it's coming from an African perspective, it's that word that you might know, you might not know, it's called Ubuntu. And Ubuntu basically means that it's important that we do work together, we do work collaboratively, especially when it comes to something like AMR. Local, so still important to work locally, but remember that this is something that travels across our borders. You know, and so, you know, as somebody that's moved to the UK, when I got there, nobody knew a single thing about my medical record. They didn't even know that I had MRSA. I've had to volunteer that kind of information. Because why? Because my medical record doesn't travel across borders. So again, you know, reiterate one thing that if we're going to talk about all these big buzzwords, One Health, global health, AMR is a global challenge, treat it like climate change because it's so important that we work together. And Ubuntu really means this is not a problem for one person to solve. It's all of our problem. You and me and everybody together, it's a collaborative approach.
Thank you so much. Okay, let's take some audience questions then. So there you go there. If you'd like to introduce yourself quickly, who you are. And guys, don't be shy. You know, ask questions if you want to.
All right, hi. Boris Azais from MSD, large pharmaceutical company known as Merck in the US. So thanks a lot for this panel and this theme of antimicrobial resistance and what we need to do about it is one of the few topics where there is a full agreement. There's a full agreement. It's, you know, and you can work on a lot of topics in public health and, you know, healthcare systems and so forth, but here, the political will is very, very strong, or should be, and the commitment of the pharmaceutical industry, the companies involved in that area, is also very strong. And, you know, this goes back, MSD, I mean, I don't want to boast, but basically, we have a long legacy in this field. We were the company that produced, I mean, the first batch of penicillin in 1941. That treated the first patient, you know, because the British guys, they couldn't, you know, the UK government couldn't fund it. So, long story short, I think the stewardship, you know, what has the industry done? So, not just products, innovation, and so forth, but also broad stewardship programs. I mean, MSD, and again, you know, this is true of other companies, GSK and so forth, involved in that state. But we've been deploying training programs globally in, you know, in India and low and middle income countries to train hospital staff about stewardship, because this is very important. We want our products to work and to deliver the benefits they're supposed to deliver. Animal health also, there are companies, including MSD, we're involved in animal health. And there is a strong case for vaccines. We have all sorts of vaccines for cattle, and vaccination of animals prevent the use of antibiotic. So that's another case for One Health. And then I guess, since 2009 at least, you had Sweden had the presidency, they made AMR their #1 priority. Then 2011, 12, UK, David Cameron made it his priority. So we've been working on this for many years. Great, you mentioned the revision of the pharmaceutical legislation and the introduction of a new incentive, but the devil is in the detail, because right now we don't really know what's going to be the shape of that incentive. The Council, the member states, are keen to reduce the scope as much as possible, to the point where it's going to be hard or Orwellian to call this an incentive. So obviously, when pharmaceutical innovation policy is designed by health authorities keen on budget considerations, which are fair, that's there's a mission in life. Cost containment is their mission in life. The problem is, when you ask them to design an incentive for innovation, well, they might not want so much innovation. I'm sorry, I'm very blunt, but that's not their mission. And I understand. I would do the same thing if I were in their position. But right now, if we really want an incentive, we really have to send a strong signal. And that's where often EU policy is a bit weak in terms of signaling, because first, it comes from the very, very end of the life cycle, and it says not just innovation, it says access, affordability, equity, and there's this policy stacking, which is fully understandable, but that sort of dilutes the message that you're trying to send 10 years before, or right now, to people, biotech companies, SMEs, who are talking to venture capitalists
Can I
or
ask
big
you what
pharma.
your question is?
All that to say, great, finally, I've been working on, transferable IP rights for all sorts of things, including neglected tropical disease. Maybe we'll see it today. Thank you.
Okay, so was your question sort of amongst all that?
My question is what else? Because
what else?
What else?
Okay.
We need revenue guarantees. What else? We know that the system is broken. There are companies that go bankrupt with an approved novel antimicrobial. They're trying to launch it in Europe. They have the approval. Yeah. They can't, because the system, the reward model that works for everything is based on volume and price.
Okay, thank you so much. So I think that the question is how to make Europe, or are you on the road to making it the best practice region, you could say, on AMR?
Thank you. So thank you also, because there were a lot in your comments, and I can agree with almost everything, of course. EU is not a bad region already. We are quite good. I would not dare to say the best, but not very far from there. We have set ambitious targets, being in the animal health sector, being through a council recommendation, even if it's not binding instrument, it was commonly agreed. And so the targets that are there have been discussed heavily with member states. So they all agree that this may be, hopefully, feasible for them to achieve. So your question is how to make even better. I would say bringing more equity, because we mentioned several times there is no borders. Again, it looks like, yeah, and what else? But indeed, there is no point Sweden being the best of the class if the neighboring country is not, and I would enlarge that not only to Europe, but to the global world. If we don't help Africa, India, South American countries, we will not get anywhere. So that's why also we try to be as active as we can in global fora, and work with all the other, I would say, international organizations. So to be a good...
So which countries are you pulling from then, would you say, in terms of creating a better understanding or awareness within Europe? Which other countries are you pulling from to understand?
I didn't...
Which other countries are you learning from?
Which countries we are learning from in the EU, you mean? Clearly, as we mentioned several times, it's true that the Nordic countries, they have a large experience with, I would say, how to diagnose a disease before providing medications. And it's, as we said, social behaviors, it's not blaming and shaming certain countries and how they have worked so far. They are in very different situations also regarding diseases, regarding the means they have, regarding the cost it may go. I would like just to add one thing, because I don't like to speak so much about benefits of and economic benefits of addressing AMR, but because at the end what we want is people in good health. But nevertheless, if we need to convince more certain member states to invest and act, we are doing currently a study with OECD to really kind of, it's a 3-year study, see exactly the economic benefits of addressing that properly, or if you want the opposite, what if we don't address it properly and the cost that it will entail. And that's sometimes a powerful argument to use.
Okay, Professor Wojcik.
I'm disciplined. I wouldn't say the system is broken. I wouldn't say that. I would be more positive. Let's look around. We have countries, you mentioned that, Netherlands, they have appropriate measures to avoid this a really fatal infection like MRSA. They separate patients to separate tracks if they are livestock keepers. The question is if we can adopt these measures, these serious measures in other member countries. So we have good examples all around Europe. We can take a benefit out of that. That's my opinion.
Okay, any more questions, Roland? Yes, please go, lady at the back there.
Hello, my name is Chelsea. I'm from Canada. So as I was hearing the panelists speaking, I just looked up on Google quickly about the difference between microbial and viral infections, as well as like what are some of the options to not use antimicrobial drugs to treat bacterial infections. And based on my limited knowledge in biochemistry, it's I'm just wondering why they're so, why is it so difficult for either patients or sometimes even healthcare providers to distinguish between viral and bacterial infections? And I think one of the things that confused me when I was reading is some of the treatments that are suggested. So for example, antibodies, and there's it's called a phage therapy, which is using like certain viral, bacterial phages. So these are viruses to target bacteria and kill them. And so, like for me, who comes from like a background, like I actually studied biochemistry as an undergrad, it's confusing. And so like, I'm just wondering how does that, like that inability to tell apart bacterial and viral infections, I think sometimes it happens within the healthcare system, like with the healthcare professionals too, because some of the infections, they actually share a lot of similar symptoms and signs, would contribute to the the AMR, like the resistance. And is there any statistics on like what percentage of misdiagnosis actually contributes to AMR versus the misuse of antibiotics, let's say through animal, I don't know, through animal livestock or like over-prescription? Because misdiagnosis, I think, is a big issue, not just for AMR, but also for other issues in the healthcare system. So I'm not sure if it's one question or multiple, but happy to hear.
I guess it's a knowledge question, really, isn't it? Yeah.
Yes.
Professor Wojcik, perhaps you want to tackle that one first? Yeah.
You're absolutely right. This is always a problem when you have a patient in front of you. Is it bacteria? Is it virus? So we don't have appropriate tools. CRP, quick test, it's something which may happen, strep test, but the real game changer was this quick testing. Now, they started with 3-in-1, COVID, flu, and what was the last one? RSV. Now we have 9-in-1. amazing. You can go to pharmacy, you can go to BIPA here in Bad Hofgastein, you can buy a quick test for $20 or even less, and then you get the result very quickly. Is it Mycoplasma? Is it rhinovirus? Or so on? So the only one thing we need is a good training on physicians and patients that they have to use this quick test to distinguish and to see these differences.
Is there a budget for it?
Yeah, and yeah, absolutely right. That it starts in grammar school. You finish biochemistry classes and studies, but we need a public awareness of engineers, of woodworkers. Anyone should understand that the virus is not a bacteria. Yeah, absolutely.
Okay, so we have just 1 minute left. So I'll just quickly go down the panel and ask you if the EU had to do just one thing in the next 12 months to make the biggest difference on AMR, what would that be? Go down.
Okay, so it would be terrible if I didn't answer this from a patient advocacy perspective. I think involve patients. We haven't mentioned that once. Involve patients. Patient-public involvement engagement is so important. If we're going to be designing meaningful interventions, meaningful policies, we need to understand exactly what it means to patients on the ground.
Perfect. Professor Wojcik?
Yeah, patient awareness, big educational campaigns.
Anna?
The same big education campaign, but including as well the use of existing tools like prevention, so broadening the education campaign.
And what are you doing the next 12 months? Go for it.
I'm not sure I can be so quick, but we have a council recommendation of 2023, and we will assess it next year to see if all the recommendation actions that are in it are fit for purpose. And whatever it comes out, adapt it accordingly to our objectives. So that's what we will do next year.
Okay, well, thank you all. Thank you to the panelists, thank you to Jan, thank you to the audience, thank you to the online audience, and of course, thank you to the Brunswick Group and OM Pharma for allowing all of us to be discussing such a massive issue. So it's been fantastic to moderate. I hope everyone's enjoyed it, and thank you for participating.